The question often comes up about the relationship between AIDS cases and poverty. And people wonder if AIDS is a disease in Africa which is spread by sexual behavior. One wonders why you find so few cases, if any, of AIDS cases among wealthy people, black, white, Indian, of any ethnicity, let's say in the case of South Africa. And I think the answer is that among people who are well-to-do or middle class, if you have the symptoms that define an AIDS case, you have a wealthy or wealthier middle-class African businessman or professional or an Indian, an Asian, or a European who has a high fever or a persistent cough or diarrhea or is losing weight, those people by definition are going to go to a doctor. They're going to seek out medical treatment, okay? Usually, they will be treated not for AIDS, but for whichever symptom it is that they are going to manifest. But in the case of impoverished Africans, it is assumed that these symptoms have come about because of their sexuality, because of their sexual behavior. What AIDS has become in Africa is a great distraction. It distracts us from the question of better food, of better clean drinking water, more appropriate ways to get rid of waste, and it puts the burden back on Africans and their alleged promiscuous sexual activities. To that extent, it is a wonderful shortcut to avoid these harder, stubborn issues about why is Africa so poor, why are its people suffering so badly. To find cases of HIV, some researchers look to refugee camps. People who are refugees are not well off. People who are refugees in these camps in Africa, I can assure you, have not eaten very well for weeks. They probably suffer from a synergy of other maladies or other illnesses. And if you understood the unreliability of these HIV tests, I would say the chances are pretty good. If you gave an HIV test looking for some constellation of antibodies in the person in a refugee camp, you get very high numbers. If the next thing you did was to advocate the giving of these toxic drugs, it seems to me that you would be committing a grotesque crime. So another aspect of all of this, and I've noticed this when I was in South Africa in 1999 and 2000. It was assumed, it was taken for granted by AIDS researchers that Africans in South Africa practiced widely promiscuous sexual behaviors. There was no particular commitment to marriage, and that that was what was driving this epidemic of HIV or HIV and AIDS. I traveled through Zululand, through KwaZulu-Natal, that one of 9 provinces in South Africa. That province is the most Christianized, most proper province in all of the country, in my opinion. People there do not have anything resembling the culture of sex or the kind of obsession with sex that you find in South Africa concentrated in the European communities. If you really want to see an open, overt, aggressive culture of sex in South Africa, you go to the North Durban beaches, where you'll see surfers and druggies, and you'll see prostitutes, you'll see porn shops. You'll go down to Cape Town to the suburbs, the eastern suburbs of Cape Town, or you go to Camps Sea Point in Cape Town. There you will find an international community of swingers. But will you find AIDS there? No, you will not find AIDS there. And the reason for that is, some of us have tried hard to point out, the connection between an AIDS case and sexual behavior has always been assumed to be there from the very beginning. But when you look closely at the research, you will discover that the connection between the two actually vanishes. I think if you ask a question, where is AIDS in Africa and where isn't there AIDS in Africa, I would suggest a kind of thinking outside the envelope answer. Again, I do not believe it is connected in any way with people's sexual behavior. I've come to believe, and there's very strong evidence for this, that there's a correlation between the number of AIDS researchers or AIDS activists or AIDS scientists in a given area of Africa and the number of AIDS cases that you are likely to find there. So where are the areas in Africa where AIDS researchers are concentrated? In South Africa, in Uganda, in Kenya, in Tanzania. Lots of cases of AIDS, allegedly. Lots of people who are said to be HIV positive. Where do you not find AIDS researchers in Africa? You don't find them in places like Somalia. You don't find them working in places like the Ivory Coast. You don't find many of them in Sudan. You don't find them in Chad. You don't find them in Burkina Faso. You won't find them in Algeria or Morocco or Egypt. And what do you know? Those are the very countries where you will not find much in the way of AIDS cases. One of the most interesting developments in terms of the scientific debate about AIDS in Africa occurred when Thabo Mbeki became the head of state of South Africa in June of 1999. He succeeded Nelson Mandela. Thabo Mbeki is trained as an economist. He's very keen on numbers, on statistics. He's the head of state of the most complicated and financially and industrially advanced country in Africa. Things about AIDS and about HIV did not make sense to Thabo Mbeki. What he began to do was to use his critical thinking skills, his love of science, and his responsibility as the head of state for the health and well-being of all of his people to find out perhaps if there wasn't another explanation for these HIV rates or these AIDS cases in South Africa. I'm afraid what President Mbeki failed to realize was that discussing medication or testing or the counting of AIDS cases is not a scientific debate. This is not something that lends itself to an academic exchange. What he did was to stir up a hornet's nest among a group of religious fanatics. The international AIDS orthodoxy behaves in a way much like evangelicals who proselytize, who are absolutely committed to their belief system, and they will attack and vilify and demonize anyone who dares to challenge what they hold so near and dear. And that is exactly what Thabo Mbeki did. I don't think he was prepared for the fanatical, organized, orchestrated attack that came down on him as a result of his asking very simple questions. Why is AIDS defined differently in Africa? How do we know that these medications are not hurting people as opposed to helping them? And so eventually he was put into an absolutely untenable, no-win situation in which most other African heads of state who respect him, who trust him, who admire him, feared challenging the international AIDS organizations because they saw the way that he and his Minister of Health and his cabinet were attacked, mocked, and berated. It's a pity that most people are unable to see the videos of the International AIDS Advisory Panel that President Mbeki put together in 2000, of which I served as a member, because their sessions were all videotaped. And there you have a good example, documented in fact, of what happens when the AIDS orthodoxy is confronted by its most severe critics. It was not a happy moment for the defenders of the AIDS orthodoxy. A question comes up about what happens to patients in clinics around Africa. Doctors find themselves short of basic medication. They find them short of staff. They find that their budgets have been savaged over the last 15 or 20 years, but there's plenty of money to distribute AIDS literature, condoms, and most damagingly, in my mind, so-called AIDS medications. A way of looking at the effects of some of this could be seen by looking at the movie The Constant Gardener by John le Carre. There you see the powerful influence of international pharmaceutical companies, big pharma so-called, on doctors struggling with a horrible patient-doctor ratio, trying to do what seems like the best thing